Welcome to the Neural Implant Podcast, where we talk with the people behind the current events and breakthroughs in brain implants in an understandable way, helping bring together various fields involved in neuroprosthetics. Here is your host, Laden Yurachek.
Hello, everyone, and welcome to the Neural Implant Podcast. Today's guest is Carles Garcia-Vitoria, and he is almost a doctor, maybe a month away from being a doctor, so we will call him a doctor soon. But he is a clinician in Spain working on pain, so kind of looking at the pain Spain market. I'm going to have a lot of fun with this. But yeah, so welcome to the show. And then you've been working on a startup as well, which we'll talk about later. But do you want to introduce yourself better than I just did?
Yeah, for sure. Thank you very much. I'm happy to be here with you today, Laden. I've heard a lot about your content, and I envy you for being able to chat with such special people. I hope to measure up. But yes, I'm actually a doctor. I'm a medical doctor. I'm a pain physician. What is going to take 1 to 2 months is to get my PhD. So it's different here in Spain. But yes, I've been working as a physician for many years now. I would say I'm just a regular anesthesiologist, but many people tell me otherwise. Basically, I apply common sense to what I do. And when I see something that could be improved, whether it's a process or a device or whatever, I give it a try. Of course, I've failed many times, but sometimes it has worked out for me. However, my main area of interest has always been regional anesthesia and pain. So now that's what I'm doing, pretty much working on pain field as a doctor.
Yeah, interesting. Okay, so physician in pain, but you also work with neurotechnology a lot, right? Like that's kind of a specialty or an interest, right? Or what do you see, I guess, the benefits of neurotechnology in this field?
Well, I'm actually working, as an anesthesiologist in the largest hospital in my country, Spain, for focusing on treating patients with work-related accidents. We say laboral hospital. So we deal with a lot of trauma, musculoskeletal damage, and there I specialize in interventional pain treatment. So we have to go to the electricity. So what I see now is that besides morphine and others, we are actually in the era of neuromodulation. What I can say here is that pain therapies in the future will certainly use pathways that we can't even imagine now. But right now, the present is neuronal stimulation. I myself implant spinal cord stimulation systems and also peripheral nerve stimulation systems. And I'm aware that there's much room for improvement, and I would be happy to be an active part in this change. So yeah, I can say that I've been also involved in other patents for Dura Mater repairment, not for renal damage, but for meningeal damage. That's what my PhD goes around. But now, yes, neuromodulation is my focus.
Yeah, interesting. Okay, so take us through this. I guess let's say you have a patient and you want to do what would be a standard treatment and what would be something that you would be like, neuromodulation would be the best way. And then what's involved in that process? What would that patient have to do? Is it a long process to have a neuromodulation, like a spinal cord stimulator, for example? Or what does, I guess, the whole process look like for a patient?
There's always a ladder, no matter if it's short or long or little or tall, but there's a ladder. So it's not the first approach for almost any patient, I would say. But yes, stimulation is to the first steps, getting closer to the first steps we consider when someone with chronic or chronicizing pain, especially for neuropathic pain, damage in the spinal cord or other structures like peripheral nerves, comes in. So it usually takes, in my kind of patients, 6 months to 1 year to decide that we are going for an implant. Of course, we do other kind of interventional procedures, but now, as I said, we can implant at many sites in the neural system. You have been talking about deep brain stimulation, which is almost magic. You also know that there's central system modulation at the spinal cord level, and there's also good and promising devices for peripheral nerve stimulation. So I do not use deep brain stimulation. This is not my field. Instead of that, we use peripheral and spinal cord. So if you want, let's talk about spinal cord. We all know that the open loop stimulation has limitation. For those who may not remember, in an open loop system, you stimulate the spinal cord without listening to what you are causing. Regardless of what happens, the system delivers energy to the spinal cord posterior columns. This causes the volume of tissue activation, or VTA, to vary a lot. With patient movements, coughing, sneezing, or lumbar flexions, the activated area of spinal cord can vary a lot. This is open loop stimulation. The consistency of the therapy, which is a good term, in terms of energy we deliver, is relatively low. It can be non-consistent. So on the other hand, a closed loop approach involves receiving real-time the information from the spinal cord and stimulating accordingly to that. So there are many ways to close the loop. In fact, for years, when I was a trainee, some systems had included accelerometers that detected small variations in the electrode position to adapt the stimulation. It's a very basic technology now. However, in the case of sudden pressure changes, such as sneeze or coughing or whatever, an accelerometer may not be sufficient. But now this is changing a lot. So the way we do this today is through the famous ECAPs, the evoked compound action potentials. They are a biosignal that indirectly reflects how the spinal cord is reacting to the stimulus. They are collected cranially, normally cranially, to the stimulus we deliver in the spinal cord, in the middle of the stimulation pathway from the stimulated area to the brain. Yeah, so that's closed loop statu quo now. I think it's going to be, for a long term, the standard of care when it comes to stimulating the spinal cord using closed loop.
Yeah, definitely. Closed loop is definitely, it makes much more sense. You only stimulate when it's needed, and you stimulate, I guess, in a smart way, and it's something that can build on itself, and the program can learn to, improve itself. So is this something that you've been seeing more in your clinic as a physician, that it's becoming more common? Or is this, what do you think about it? Or like how's it changing your work?
It's changing. I guess there's always let's say, commercial pressure on this. So what big market players discover or invest in, they want to squeeze a bit and start making the physicians implant this and not that. But of course, there's a significant advance. It's now, at least in Spain, we are now implanting this kind of spinal cord stimulations with the closed loop based on evoked compound action potential and other similar technologies. And I do think that it has biological sense, let's say, and now is starting getting clinical evidence, which is not always the same, because there's always mysteries. But the thing is that, to be honest, an evoked potential is complex to measure. Let's not fool ourselves. There are many biases that can confuse you. Generally, physically spacing the emission and reception helps filter which potentials are produced by the spinal response and which are a direct consequence of the stimulation spark. So even if it sounds perfect, the evoked compound action potential is complex to measure. That's the reality. That's why we are now working on new approaches to listen to the spinal cord.
Yeah, interesting. That's a great segue. Okay, so let's talk about these new approaches. This is actually the reason that we're talking is one of these new approaches. So do you want to talk about this? You're involved in a startup, you're developing a technology to better listen and to better stimulate, right? Do you want to talk about that?
Yeah, that's better listening. It's a very good term in this case. So, yeah, we have a very clear idea. So we founded a company to try to get the most out of this in terms of clinical efficacy in the last term, and at the very beginning, good and solid research papers. So we have that idea, which is the epidural space. When we implant conventional spinal cord stimulator, we do via IPG, the generator, which is implanted subcutaneously, and then what we really implant near the spinal cord is the lead, the epidural lead. Epidural space is very common for anesthesiologists such as me. We use it also for pregnant people, pregnant women that are going to deliver a baby. We administer analgesia in the epidural space. We also do it for some trauma surgeries. So it's very useful for us. But nowadays, we still implant the epidural space. We still use the epidural space as the site of implantation of the leads. So we think that it's not the best site for stimulation, but since the gold standard is becoming listening and stimulating, and not only stimulating, so this is at the gold standard begins to be the closed loop, it's also not the best site for listening. So that's what closes this circle. Okay, so placing a natural barrier, which is the Dura Mater or meningeal complex between the spinal cord, which is the target, and the lead, placing the Dura Mater in between, this is making complicated the listening and the stimulating. So we lost approximately 90% of the energy. So also with the evoked computational potentials, the measurement is going to be less accurate. The technology has advanced enough to develop implants capable of being in the thecal sac or subarachnoid space, and that's where we come in. In fact, for other purposes, devices have been implanted in that space, subarachnoidal space, for decades, so such as morphine pumps or showers. So we believe that we have the option to govern that subarachnoid space to get closer to the site of action. So that's why we have created Spinally. Spinally is the startup we are ruling now, which promises to be the company that first delivers the intrathecal spinal cord stimulation for the future.
Yeah, it definitely makes a lot of sense. I mean, of course, if you want to stimulate, you should get as close as possible, not have any barriers. Kind of like if you have a speaker playing music, you would put it in the room that you are in, not in a next room, and then try to listen or something like this. So it just much more logical. But it's too logical, I would say. Like, why hasn't this been done before? And why is it only being done now? Does the more cerebrospinal fluid leak or something like this, or why? What's maybe the downside?
Yeah, that's one of the downsides. But as said, what we have been doing for decades is implanting other devices even larger in the intrathecal sac. So cerebrospinal fluid leak is my PhD motto. So I'm kind of an expert in that because I have been working in sheep model for years, and now I will be presenting my results. Dura Mater barrier is very elastic, so it closes 90%, 80% approx in the first 30 seconds after a trauma. But besides that, we are going to, as we can get intrathecal and listen better and emit better, we can use thinner implants. And by thinner, I mean instead of 1.3 millimeters, we go to 0.5 millimeters implants thickness. So the trauma to the meningeal sac is even smaller. So that's not the main concern about this, but the main concern is obviously regulatory aspects, and we have a long pathway to cover still. Why don't people stimulate intrathecally? They have already stimulated and with good results in the past, but technology wasn't ready to deliver such a thin implant. So we used open durotomy to insert electrodes intrathecally, and we have also seen other much more invasive techniques. As you know, also not only Neuralink, but other people is placing very close to the brain electrodes and other devices. And what we propose in the spinal cord is similar, but with a tiny percutaneous lead. So we don't see that as a danger. The danger is always to cover the step-by-step systematically approach of the research.
Yeah, that's very interesting. Yeah, for sure. I think the existing medical device technologies or companies, they're very conservative, and they're probably not going to be wanting to cannibalize or destroy their previous markets. So you definitely need to have somebody else come in and improve things. And then the medical approval process is very long and difficult. So it is a uphill battle, I think. So where along in this process are you? What are you doing? I guess what's your role too? And then how far along are you?
Now it's time to demonstrate the non-inferiority in terms of recruitment of dorsal column fibers when stimulating intrathecal and epidural leads. So we are developing the implant. We are doing it with some good friends from the Australia Neobionica Institute. And if everything goes like it's going now, at the late 24, let's say, we will be doing this in vivo model sheep. Okay, so that's pretty impressive. We have a great expectation on what's this first in vivo test going to look like. And yes, and regarding the other question, yeah, they don't want to cannibalize. I'm not into Medtronics or Boston head, but of course, there's part of this, and also because once you get an inertial and you have developed a lot of your development has been investment into the IPG, the generator. They are perfecting the IPG. They have the cables, the electrodes have remained the same, basically the same. They only changing the octopolarity or quadripolarity and so on. But the investment has been in IPG. So this is what we want to at least try to change.
Okay, cool. Yeah, that's interesting. Okay, and then in terms of the leads, the actual electrodes, the implantable electrodes, is that something that you guys already have, or are you guys working with Neobionica for that, or where are you getting those from?
Yeah, we are working with Neobionica for the leads. We don't produce our first lead. We will produce it once we have the definitive lead tested in vivo. That's good because we don't need to invent the wheel. So I cannot say everything what I would like to say now, but we are using very well-known materials because they have very good potential for being the lead that solves the intrathecal problem. So yes, there are good friends in Australia that are very prepared to deliver the best lead ever for intrathecal purposes.
Yeah, great. Very cool. Okay, so and then you guys are raising money right now. Do you want to talk about that? Because that's also another reason you're on the show, right?
Yeah, that's always good moment for getting the correct amount of money. Of course, we are not obsessed about this, but for the very first test in sheep, the trials are going to cost money. They're going to change many things. So companies going to boost after first in vivo results. So I guess it's a good moment to invest in this technology. Of course, we are now raising a little amount of money, with around 600K. We have committed so far money from not only grants we won, but also serious investors in Spain. We're going to go public for this little round. And I think it's going to be very, very fast round. But yes, your audience may be also interested in collaborating in this. I don't know. I'm very open to that.
Okay, and then you guys are launching a crowdfunding campaign. Do you want to talk about that or no?
Yes, we decided to make it accessible to not every doctor, but every bio expert in Europe. Also from the other parts of the world, you can invest in our round. But yes, we crowdfunded this because I have been part of previous crowdfunding campaigns as a leader and also as an investor, and I have good memories of that. And I think it's very, very nice feeling to let people kind of rule the first stages of the company that has great potential. So yes, that's what makes this is to democratize the possibilities of people to invest in neuroscience, because if not, you have to have billions to first make your first investment in neurotech.
Yeah, really. People can be part of the process. Yeah, it is a uncommon thing. I don't think I've seen medical device companies be, crowdfunded. Usually it's more, a cooler company or, whatever, some kind of electrical thing or something, electronics. Is this something that you've seen? Have you been a part of these kind of medical device crowdfunding campaigns or is this kind of a new thing for everybody?
Now, as world changes, the capacity of the people to be part of the change is increasing. So individuals are taking power in biosciences and medtech and drug. This is going to be the laggard part of the curve. So they are going to be the last because of the regulatory we were talking about. But of course, this is going to change. It's not a kickstart and for useless devices, but also for important things such as health devices. So yes, I've been part of this. I'm actually an investor in some of little companies that are doing great. So I think the return of investment is going to make people happy, besides being happy for reasonable things as contributing to pain relief and also for tax advantages, of course. But yes, I've been also leading some funding campaigns in past. I also, when I was a trainee, I also devised and created a play card game for ruling a hospital. It was a joke game, but it was my first contact with the crowdfunding. Me and my colleagues developed a card game. So I was just getting in touch with the crowdfunding possibilities, and now it's time to make it seriously for a very good cause.
Yeah, cool. That's really interesting. That's you've done this before. You know what's involved, and how did that go? The card game.
Yeah, it was very, very good. Now it's sold out, so we are not getting a new campaign for that because it's just a happy moment in our lives. But it changed the way we played games with doctors in Spain. Played games, but it was very funny. But of course, now it's time to change to more serious things.
Yeah, for sure. Well, I think this is great, and I really wish you a lot of luck with this, and hopefully people and the people of Spain will not complain about the pain that they have, and they can have
You were
these.
preparing this the
I've
whole
been thinking
interview.
about it. I've been thinking about it. Yeah, I want to feel. I don't know. There's
That's
something.
great.
Yeah, we can make some good dad jokes about this. But yeah, so is there anything that we didn't cover that you wanted to mention?
I think we got a general idea of what our interest is or focus in the scientific part. There's also obviously an economic part in which people can be interested. Of course, we are open to listen to them and to come. There's people nowadays committing some money for this ongoing round. So yeah, we are open to that. But yes, I wanted to make people aware that we can change things. We can use the new, not materials, but capabilities of fabrication for minimizing implants and getting a very, very good way of pain relief. Just to mention that our models and also others models predict that we can invoke deeper layers of the spinal cord with the positioning of the intrathecal electrodes. That is obviously going to happen as well for the listening. We can listen deeper in the deeper tracts of neurons. So this is what I think is going to make a lot of noise in the world of pain in 1 year.
Yeah. Making a lot of noise by reducing the noise. That's really cool. Yeah, I think it's good. And then like you said, 90% less energy. So batteries, IPGs, they'll last longer. I think there's a lot of benefits for this. And like you said, it really wasn't possible before with previous fabrication techniques, but now it is possible, but just somebody has to do it. So I'm glad that you guys are doing it, and hopefully it can spread from pain to maybe other things that are useful as well. So yeah, this has been great. Carles, thank you so much for coming on. I've really enjoyed this.
Million thanks for your work. It's amazing. I hope we can see or hear from each other in the near future, Ladan.
Okay, here. Okay, this is Laden. This is what I should have said during the interview. That it's a shame that most complain about the rain in Spain falling mainly on the plains, but your patients complain about the pain, especially on plains. Their refrain is the strain of the plain has gained again and again again and again. I should have said that.
Hope you enjoyed the show and were able to learn something new, bringing together different fields in novel ways. Until next time on the Neural Implant Podcast.